Assalamu alaikum and welcome to this recorded lecture on lower genital tract infections. I have to move on this first slide usually by using this device. Okay, fine. So we're going to understand the causes of lower genital tract infection, discuss diagnosis and management, and appreciate the importance to recognize physiological discharge and also the pitfalls in diagnosis of lower genital tract infections. So prevalence varies, but it is a very common complaint. In the literature, you find prevalences between 40 to 50% for bacterial vaginosis, around 20 to 25% for vaginal candidiasis, and 15 to 20% for trichomoniasis. Altogether, you have to remember that 30% of complaints go without a clear diagnosis, even after examination, investigation, everything, the diagnosis remains unclear. Just take a piece of paper and a pen again, as in all of my lectures, and write down the causative organisms that you think are responsible for lower genital tract infections. Okay, so the most common I already have discussed, which is Candida species, bacterial vaginosis. Bacterial vaginosis is actually not a causative organism, but it's an expression. Bacterial vaginosis is caused by the anaerobes that are commonly found in the vagina. Trichomonas vaginalis, Neisseria gonorrhea, Chlamydia trichomonas, and also herpes simplex 1 and 2 can be causative organisms. These are just the common ones, and those that have a specific clinical picture. There are, of course, others as well causing such problems. What is the presentation of women with lower genital tract infections? So when do you have to suspect a genital tract infections? So let us look at them one by one, because all of them have slightly different presentations, but I have to warn you now that you cannot actually come to a clear diagnosis just from the clinical picture or the clinical presentation of the patient. Okay, so first of all, the Candida species. They often present with vaginal and vulval pruritus and soreness. They also might have white cottage cheese discharge. Bacterial vaginosis, on the other hand, usually has no symptoms, so no soreness, no pain or pruritus, but patients might complain of a copious, smelly, grey and offensive vaginal discharge. Sometimes they will tell you that this discharge, these symptoms are worse after menstruation, after sexual intercourse, or in hot weather. Bacterial vaginosis is commonly caused by Gardnerella vaginalis, which is the kind of typical organism for this, but also Mycoplasma hominis and all other anaerobes are also possible causes. Trichomonas vaginalis causes copious grey, white discharge. Neisseria gonorrhea is frequently asymptomatic, and we have already discussed this when we discussed sexually transmitted infections, but they might also have a yellowish discharge and abdominal pain. Usually gonorrhea is associated with an upper genital tract infection, but it can also cause lower genital tract infections. Chlamydia trichomonas is mostly found in patients under 21. It is also frequently asymptomatic. It is usually associated with upper genital tract infections, but I have again mentioned it here for the completeness of the lecture. Finally, the presentation of herpes simplex is a bit different from the other infections. Herpes simplex is actually a clinical diagnosis, so the clinical picture can lead you to the diagnosis. Multiple groups of vesicles appear firstly, followed by ulceration of these vesicles and new groups of vesicles coming up in the area. It's usually very painful, especially in the first infection, and it might even cause urinary retention because of the pain that it might cause women to pass urine. So they kind of suffer from an involuntary urinary retention. The pain they experience is usually due to the urine running over those lesions. Vaginal symptoms are a very common cause for visiting gynecological clinics. So this number, 10 million office visits annually, is from the US, but also this is common everywhere in the world. The three most common etiologies for lower genital tract infections are vaginal candidiasis, bacterial vaginosis, and trichomoniasis. And those we're going to talk a little bit more about. However, it is very important to recognize the physiological discharge that women have. Okay, so often women might recognize that they have some discharge and associate that with an infection. Okay, what I'm telling you is that not every discharge will be representing an infection or associated with an infection. Okay, so vaginal discharge is present throughout the month. It might also change due to the hormonal changes in the cycle of the patient, and it is not associated always with an infection. The distinction can be problematic, and there's not that much literature available on normal vaginal discharge. Furthermore, you sometimes find increases in discharge due to throughout the cycle, also in pregnancy, and when women start using the oral contraceptive pills, progesterone-only pills change the occurrence of the cervical mucus. Also, the combined oral contraceptive pills have some impact. So therefore, it can be very different, very sometimes difficult to distinguish normal vaginal discharge from those that is not normal. Even normal vaginal discharge can be accompanied by irritative symptoms, especially if it's copious discharge. It can cause skin symptoms that the woman finds or reports to be irritating her skin. So after I gave you this little talk about the normal vaginal discharge, how accurate do you think symptoms are? So if a woman comes to you and describes she has some discharge, then she describes the discharge to you, how accurate will these symptoms be with regards to which infection she has, or if she has an infection? So I hope you have all kind of been led up the right path by me, because actually symptoms are not that accurate for knowing what problem the patient presents with. Okay, the only thing that has been described as being somewhat leading to somewhat of a more accurate diagnosis is cheesy discharge. So the typical cottage cheese discharge that you find with candidiasis, but other or less likely if described as watery, but other characteristics have not been very helpful in making the diagnosis. So basically your diagnosis depends very much on your examination, but as well on the culture results that you get and the investigations you do. So after you have completed the history, that's why, so you have to take a history. In your history, you have to, of course, include um, the presentation symptoms and ask the patient why she comes to see you. Let her describe her symptoms to you. But then you have to also ask for any other symptoms, so any pain, any abnormal bleeding, any postcoital bleeding, any of such symptoms that might be also associated with her problem that she presents to you with. But a minute description of the type of discharge will not be helpful to you in your making a diagnosis. So I hear you often ask color, smell, and on. A minute description of that might not actually be that helpful. So examination is very important, and that should include an abdominal examination. That is always also important in gynecology because you do not want to miss a pelvic mass. A speculum examination is important. You want to have a look at the cervix. You want to actually see the discharge, maybe even smell the discharge. A wet prep can be very helpful to kind of get an idea of what might be going on, but very essential are swabs for culture, to take swabs for culture during your examination. And also the bimanual examination is important to exclude upper genital tract infections or PID. So, how do we come to the diagnosis? We ask for the symptoms. So, is discharge? Is there odor? Do they have pruritus, or have they got any pain? What is the? You can ask about how they describe the discharge. Very important is to have a look also at the outer genitalia, because you want to see if there are any signs, excoriation, so signs of pruritus, maybe erythema, and also you have to look at the discharge. It is very important, as I said, that you sample the vaginal discharge from the posterior fornix. This is also called a high vaginal swab. Okay. But before you just put this sample into the swab and send it as a swab, you can test the pH, which will help you a little bit, and you can look at it under the microscope. Okay, you do this simply by putting a bit of the discharge on a kind of glass slide. You cover it with the little glass, and you look at it under the microscope. To do the whiff test for diagnosis of bacterial vaginosis or anaerobes, you just add some potassium chloride to it to kind of get the kind of typical smell, fishy smell of the amine. Now, if we look at the most common bacterial or lower genital tract infections that women present with now. First of all, there's bacterial vaginosis. What is bacterial vaginosis? You were absolutely right if you were thinking that bacterial vaginosis is not actually a proper infection. Bacterial vaginosis is an overgrowth of anaerobe bacteria which are present in the vagina normally. And by the conditions changing, they get the chance to overgrow and become more than the lactobacilli, which are also present in the vagina and make the vagina acidic. Some triggers that can cause such an overgrowth of anaerobe bacteria can be that women took antibiotics, for example, for a UTI or any other reason. It could be that they have menstruation or sexual intercourse, because both of those can kind of make the conditions in the vagina more alkaline, and this can be also a trigger. Sometimes it is just hot weather, and sometimes there's no identifiable trigger for such infections for such conditions. The important important is to understand that bacterial vaginosis is a recurring condition. So even if you treat it, it might recur at a later stage. Okay, so let us just go over this again with this slide to help you in text. This is the most common cause for vaginitis in premenopausal women. It is associated with a relative decrease of lactobacilli and an increase in anaerobes such as Gardnerella vaginalis, Mycoplasma hominis, and Streptococci can also be there, or anaerobe G-rods. The exact mechanism remains unclear why this takes place. The predisposing factors we have already mentioned. This might be an alkaline or switch from the acidic pH of the vagina to an alkaline pH, which might be associated with menstruation or following sexual intercourse, maybe hot weather or tight-fitting clothes. So, clinical features. What are the clinical features associated with bacterial vaginosis? You're absolutely right when you will say that 50% are asymptomatic. So there are 50% of women that have bacterial vaginosis who are not actually aware that they have bacterial vaginosis. And in healthy women who are not pregnant, this is okay. They do not need bacterial vaginosis will go away again spontaneously, resolve spontaneously. So there's no need to, if the patient is not bothered by it, she can be left alone in that sense. Other women find that there's an unpleasant, fishy smelling discharge, but itching and inflammation are very uncommon. They are not usually associated with bacterial vaginosis. Here you can see two pictures. There's a speculum picture which shows the kind of frothy whitish discharge of bacterial vaginosis. Just from looking at the discharge, you could not maybe distinguish it from the discharge, normal physiological discharge, or discharge associated with trichomonas, but the smell will give it away. And there's another picture again of the discharge. Another one. So the reason I show you the discharge is that it is quite copious together with bacterial vaginosis. So we have Amstel criteria to help us make a diagnosis, but they are rarely used. As it is quite a common condition, just the whiff test and the presentation will be enough for us to make the diagnosis. So it's a whitish grayish discharge with the vaginal pH of over 4.5, a positive whiff test, so you get the fishy smell when you kind of smell the discharge, and you find clue cells on the wet mound, and I will show you clue cells and it kind of tell you what they are. The first three, the problem with the Amstel criteria are that the first three criteria can overlap with trichomonas, but clue cells are quite specific for bacterial vaginosis. And here you find clue cells. They are basically white leukocytes which have Gardnerella vaginalis attached to them. And this is why they are called clue cells. And the picture on the left really shows these clue cells to you very well. And you can see them under the wet mount, or on the wet mount of the microscope. But you can also send them away, of course, for microscopy, and then they could also identify them in the lab for you. Unfortunately, in some circumstances, although bacterial vaginosis is associated with complications, although generally it is more an annoyance than a real kind of pathological condition. But there are some risks associated regarding to bacterial vaginosis causing preterm labor in pregnant women. There is, of course, especially in the postpartum period, an association with puerperal sepsis or fever, and or even endometritis. In the following hysterectomy, It can be that bacterial vaginosis causes some vaginal cuff infections, and they can be quite serious. Therefore, all women undergoing vaginal hysterectomy should have metronidazole prior, or not only vaginal, also abdominal hysterectomy, should have metronidazole as a pre-medication to prevent anaerobes causing such a problem. It can cause a post-abortal infection if it's present, and can be associated with other sexually transmitted illnesses or even HIV. So you can see that all of these complications occur not in healthy women who are not pregnant and have no other problem and no other intervention, but these are mostly associated with some instrumentation of the uterus or other intervention near the vagina, even childbirth. What is the treatment for bacterial vaginosis? So bacterial vaginosis only needs to be treated if it causes a problem to the woman, so if it makes symptoms, or if the patient, as I said, undergoes an intervention, is post-delivery, or pregnant, especially in the first trimester or second trimester. So, as I said, it may resolve spontaneously, otherwise just treat if it's asymptomatic or prior to total abdominal hysterectomy or IUD placement, or in pregnant women who have a history of preterm labor or preterm delivery. There's no need to treat sexual partners of women who have bacterial vaginosis. The treatment is metronidazole, which is of course very effective for anaerobes. This can be done in divided doses, but it is usually much more effective if you give the treatment in one single dose, which is 2 grams of metronidazole in one single dose. This is more effective because the woman will be compliant to it. So if she takes one dose, this is taken. It's not that she has to remember taking it every day. So a single dose therapy is usually the easiest thing to treat bacterial vaginosis. There's also topical treatments available for this problem, and these can be clindamycin vaginal gel. They can also be metronidazole gel or other triol gels, which might also be available. The inconvenient thing about these vaginal gels are that they have to be applied every day for 7 days usually. So this is less likely that the patient will be compliant with this and complete her treatment than if she just has a single dose treatment of 5 tablets, or 4 tablets rather, in one go. So what is it that you have to explain to this patient? You have to tell her and impress on her that she should avoid female hair hygiene products, as these can also kind of trigger bacterial vaginosis, and also she should avoid soap, especially if she has recurrent problems. Then just washing with water is the best for her that she can do. She should avoid tight-fitting clothes, and she should always avoid wear cotton. You should warn her at this stage that she might have recurring infections and that she might need repeated doses for treatment. Okay, let us go then to vulvovaginal candidiasis. Just have a few thoughts about this yourself, what it is, what causes it, and how does it present. This is the 1/3 it causes 1/3 of all vaginitis cases. Up to 75% of premenopausal women will have had vulvovaginal candidiasis at some point in their lives. It is rare before the menarche, but 50% of all women will have had it by the age of 25, and it is less common in postmenopausal women. What are the predisposing factors for vulvovaginal candidiasis? So the predisposing factors are antibiotics, taking antibiotics, diabetes mellitus. So women who suffer from diabetes mellitus are very prone to vulvovaginal candidiasis. Some women who take oral contraceptive pills have reported to have are more likely to this problem. Contraceptive devices can sometimes be associated with it, although I have to say for these 2 points, these are controversial and the evidence is not that clear. But pregnancy is definitely another association. So women in pregnancy are more prone to candida infections than outside of pregnancy. The clinical features are quite different to bacterial vaginosis. They also have a discharge, which can be described sometimes as kind of a cotton cheese white or cheesy discharge, but it is not smelly. On the other hand, the most problematic symptoms are that these women have some soreness and pruritus, and this can be quite distressing to them. And this is usually also the reason for them to kind of present to the doctor. So also dyspareunia can be a result of this. These are some clinical features that you can see on the outer genitalia. The vulvovaginal candidiasis can be a condition of the vagina, but also of the skin. And you can see on the left picture quite a large area kind of affected by erythema and soreness. On the right picture, you see the typical lacerations for a vulvovaginal candidiasis. How do you make the diagnosis for vulvovaginal candidiasis? You will need a swab generally to be sure of this problem, but you can get an idea about it by her typical features, by this clinical picture that you might see in combination with her clinical with her with an examination. It is possible to see the yeast buds and spores or hyphae on the under the microscope on a wet mount, and I will show you a picture of that in the next slide. You can just take a bit of the discharge, put it on a glass slide, then you put a little bit of potassium chloride solution on it, put the glass on, and it will kind of reveal the hyphae of the budding yeast in the discharge. However, this test is not as reliable as a culture. So in those patients that have a proven culture, this test under the microscope, in 50% of these cases, this was negative. So here you see the picture of the wet mount, and you see kind of a little error at the hyphae and how they present on this page under the microscope. Treatment is most uncomplicated infections improve after a few days, and not everybody needs treatment. Especially if there's no associated symptoms, there's no need for treatment. Severe infections, though, may require a longer treatment for 14 days to improve. Okay, generally the treatment can be given over a period of kind of 3 days, sometimes a week, or no treatment at all. There's a multitude of different treatments available, and we'll come to this in a minute. And at this point, I just want to say that there's no route of administration that is better than the other. So these patients can take oral treatment. They can also take vaginal treatment, creams and pessaries, and all of these are kind of effective. It depends very much on what the patient prefers, and if you choose and discuss with her what sort of treatment she prefers, it will also be the treatment she's most likely to adhere to, and therefore this is the treatment that is going to be most effective for this patient. So the treatment is usually done with the imidazoles, which can be miconazole, clotrimazole, butoconazole, thiaconazole, and these are all available as creams and also pessaries. You can also use fluconazole as a treatment, and this is a very effective oral treatment. This is especially useful when there's a larger area affected by candidiasis, and it can be also given as a one-off dose of 150 milligrams fluconazole, and this is usually something that eliminates candidiasis from the whole body. Candidiasis is also one of these infections that can recur under some conditions, and patients have to be warned that it can recur. As we said, especially after taking antibiotics for UTI, for upper respiratory tract infections, or any other problem, this can give the patient the problem that they have candidiasis. So let us go over and talk about Trichomonas. So what is Trichomonas? Yes, Trichomonas is a flagellated protozoan. Trichomonas vaginalis causes this trichomoniasis. It's the third most common vaginitis. It infects vagina, urethra, and paraurethral glands. It is virtually always sexually transmitted, but there are or have been reported cases where women were infected without sexual transmission, and it is not quite clear how this was possible, but it might have to do with unsanitary toilets or something such like. So what is the clinical presentation of trichomoniasis? So this ranges from being asymptomatic to a severe acute inflammatory disease. It can cause purulent, malodorous, thin, frothy discharge, can be associated with dysuria, dyspareunia, and pruritus. A very common or very flagship feature of it is the strawberry cervix. So here you can see a picture of the strawberry cervix on the left, and you can see this kind of infection of the cervix causing this picture. What causes this picture are actually little capillaries in the cervix, which become visible due to the infection of the cervix with Trichomonas. So this is a clinical picture, but it's not diagnostic. The cervix, it's kind of just the picture of an infection of the cervix, and it can happen with other organisms and other pathogens as well. It is very important to do a speculum examination in Trichomonas, not only to have a look at the cervix, but also to get some of the discharge and put the discharge on a glass slide, put on top of it the little glass kind of cover, and then you can look at it under the microscope, and this will definitely make a definite diagnosis, because you will see the little flagellated protozoa move around in the discharge, and this is very obvious, and you cannot make if you see this, you will definitely make the correct diagnosis. If this is not seen but you suspect it, you of course have to still do cultures. So what is the treatment for Trichomonas? So here the treatment again is metronidazole, but this should not be given as a single dose, but it should be a full 7-dose treatment with 2 grams or 500 grams twice a day for 7 days is best. Topical treatment should be avoided in Trichomonas, so it should not be treated by topical treatment. And very important is to treat the sexual partner simultaneously, because if one partner is not treated, they will give it back to the other partner, and it will go back and forth between the two, and they will not get rid of it. They have to be treated at the same time, and they have to have abstinence during this time. Sometimes you find that you have a refractory treatment, so meaning that patients do not respond to the treatment. This is mostly due to the fact that one of the partners is not adhering to the treatment properly. Now we come to herpes simplex. What is herpes simplex? It is also called the silent epidemic in the USA. It's very common in the USA, and is supposed to kind of be one of the most common sexually transmitted infections in the USA. It is, of course, caused by the herpes simplex virus. We have two types. We have type 1 and type 2. Type 1 is commonly associated with orolabial infections of herpes simplex infections, and type 2 is usually associated with genital infections, but this is not exclusive. You do find type 1 HSV type 1 in genital infections, and you also find HSV type 2 in orolabial infections. We usually have a primary infection, which is very acute and associated with a lot of symptoms. And following this, and it always needs treatment, and following this, once it's cleared, you might get recurrent infections. How do you transmit herpes simplex? Herpes simplex is usually transmitted by intimate sexual contact. This can be skin-to-skin contact, or it can be oral contact or genital contact. It can also rarely be transmitted vertically, but this is only really the case when a mother has got a primary herpes simplex infection at the time of delivery of the baby, and she has lesions in the birth canal. Then you might find in transmission to the baby. In all other cases, especially in recurrent infections, this is very unlikely, and this is unlikely because, of course, the mother already has antibodies, and she protects her own baby by transmitting those antibodies to the baby via the placenta. So just to kind of complete this part, herpes simplex is not usually a reason to perform a cesarean section unless the mother has a primary herpes simplex infection with florid lesions in the cervical canal. Another way of transmission is what is called auto-inoculation, and this is transmission from one side to another. Typically, it is the finger that touches the side, and then you have kind of another lesion on the finger, and this is called the Whitlow lesion. So let us think about the clinical pictures. You have new lesions that form for about 10 days. So it starts with new lesions that are usually groups of vesicles. These groups of vesicles, they then become ulcers. But while these some become ulcers, new groups of vesicles form. So you have usually in later days of the disease, you have vesicles and ulcers kind of present at the same time. It is a clinical picture that is very easy to recognize, and you can make a clinical diagnosis for herpes simplex. You have virus shedding for 2 to 10 days. This is important because while there's virus shedding, there can also be transmission to another person. Recurrent herpes simplex is quite common with HSV2. However, not all women have recurrent herpes simplex, and recurrences can be at different times. So some women never have recurrences, others have quite regular recurrences with once, twice, 3, 4 times a year. They can always be quite annoying, and it's a very difficult situation if they have herpes simplex recurrences. You can isolate the virus on a culture by taking a culture from either the vesicle, which is full of viruses, or the bottom of the ulcer. This is done then by direct detection of the virus PCR. Another way of finding a virus is, or you can also look for antibodies, but this is maybe not so exact, because herpes simplex virus is quite common in patients. Just going to wait until the ADAN is over now. Just read these goals in this time, the management goals. So oral antiviral treatment is very important. And I know all of you, this is acyclovir. Acyclovir is a treatment that requires 5 times a day taking of the tablet, which might be very difficult for patients to adhere to. Therefore, I advise, and usually valacyclovir is the treatment of choice, which is only taken twice a day. So in summary, vaginal discharge is one of the commonest complaints presenting to gynecological clinics. Associated signs and symptoms are not accurate in making the diagnosis, but give you an idea. Cultures need to be done for accurate diagnosis. A large proportion of women who think they have got a vaginal infection might represent with physiological discharge. Treatment trials and monitoring of effectiveness can be a good way forward. For example, if a patient comes to see you with a burning feeling and itching, you examine her and she has cottage cheese discharge and you see some lacerations on her skin, you probably suspect this patient most likely has candida. And if this is the case, you can give her a treatment trial before you do the further investigations. Usually they respond well to the treatment, and this can then be also a kind of a confirmation that this was the problem she has presented with. Okay, thank you very much. And if you have any questions, please remember to write them down. And when we have our kind of forum session, we can then discuss the questions. Thank you very much for listening.